So next up, I'd like to invite Jill Sangha to come forward and share with us the work that she has done over the last 2 years.
Thanks, Jocelyn. So I'm going to be talking about rediscovering the human side of medicine through our journey of building a curriculum program through our local Department of Pediatrics. And so this is our story. I have spent the last 15 years working in healthcare as a social worker. I have had the privilege to bear witness to the worlds of others through their sharing of stories. Many of these stories have taught me a lesson that I needed to learn. I am reliant on these stories to do my best work as a social worker. In the field of healthcare, we are all reliant on these stories to do our best job. So why don't we always seek these stories from patients? If, in fact, these stories offer us key information about the world in which they live and its impact on their health. It's not that easy. Time, pressure, and accountability to diagnose and treat, it can be consuming and comes at the expense of cultivating other humanistic skills. I was fortunate to have received the training necessary to prepare me for my role to elicit these stories while addressing the determinants of health. I was curious whether we could influence other health professionals with the same goals in mind by educating them early and often. I had a big idea. I approached my physician colleagues and I made my pitch. We spent time weeding through literature focused on social peds curriculum. Most of what we found had implemented the curriculum within a block. However, something was missing. We wanted to teach residents a different way of thinking about all of the care that they provided. We landed on a curriculum that would be both interwoven and extended over existing training. We got to work engaging residents, faculty, patients and families, community experts, and other academic departments. When this initial work was done, we had met with more than 150 people. They shared their ideas, highlighted challenges, and pointed to gaps within the curriculum. We had listened and then made our cause for commitment moving forward. We also took this time to develop a common understanding of social pediatrics. We built consensus among all those that we engaged. We landed on a definition that would be owned by all of us and agreed to a vision for the curriculum program as we move forward. We had heard loud and clear what mattered most to people when caring for others. We used these values to create our own guiding principles for future development of our curriculum. The principles included learning from others, social justice, empathy and humanism, diversity, health promotion, self-reflection. These principles would become our compass. We had received some cautionary words early on from another wise AMS fellow to delicately build a curriculum that would not further stigmatize the most vulnerable. We made it our commitment to integrate both self-reflection and particularly an examination of our biases at every possible opportunity. These opportunities for self-reflection were established through one-on-one meetings with a community expert. We quickly realized this practice of reflection was not going to be intuitive to everyone, so we created materials for residents and the facilitators to help with these meetings and promote deeper reflection. We were eager to establish opportunities for residents to step outside their traditional role within the hospital. We wanted to expose residents to community conditions, resources, and the lived experience of the most vulnerable. We were determined to bring back the humanism in their residency training. We decided to integrate these experiences into their clinical rotations. Our excitement quickly faded when we got feedback from residents questioning the relevancy of some of these experiences. It was a light bulb moment. We had expected residents to connect what they were experiencing with their physician role. We took their feedback and went to work creating structured learning experiences. The department had been exploring how they would incorporate advocacy training into the larger program. We welcomed the opportunity to include this as part of Social Peds. An advocacy initiative was integrated within the first 2 years of training. Residents were supported in learning the skills to advocate with and not just for patients and populations. We introduced the role of coaches to enable residents to make the most of the experience. This coaching relationship started at the beginning of their training and extended through their advocacy project. Coaches were selected as being experts in the field, and there were lawyers, public health nurses, social workers, and others. They did one-on-one coaching with residents. With much focus on the medical expert role during residency training, we were eager to dedicate time for residents to practice the more humanistic skills. We introduced residents to simulations focused on poverty, solution-focused therapy skills, and crucial conversations. These experiences have proven to be our greatest strength. As it turns out, the curriculum has been as much about the importance of storytelling for clinical decision-making as it has been about teaching residents about social pediatrics. Stories are vital to our work, and yet we have not prepared residents to elicit or to actively listen to these stories. It is important residents are given ample opportunity to learn how to elicit these stories and use them as an effective diagnostic tool. Work is already underway to incorporate this learning into our curriculum to better prepare residents for storytelling during their training and as their role as a physician. Through the social pediatrics curriculum, we have pushed the boundaries on the traditional model of medical education in which physicians teach and assess physicians. We have introduced other experts into the teaching and resident assessment model. In doing so, we have experienced several moments where a clear power imbalance between physicians and others has challenged our success. Perceived fear, reprisal, discrediting have been apparent at various times during this project. If we are to see this program to its full potential, we will need to continue to talk about the elephant in the room. Frank, honest conversations has been our only way forward, and respecting what we all bring to the table. Even though this fellowship has come to an end, this is just our beginning. Research and evaluation is underway and will continue concurrently with the curriculum. I am excited about our possibilities. We have started to identify opportunities within clerkship where we are able to bring a lens to the social determinants of health, and have been recently asked to redesign the social medicine curriculum program for our undergraduate students. The development of the Social Peds curriculum program has been a labor of love, and without the generosity of AMS, this would not have been possible. For this, I am truly grateful. I also want to acknowledge the amazing team that we had, because this curriculum program really did take a village, and so we had physicians that joined on who took the leadership role. And I also want to acknowledge Saad with the Center of Research and Innovation at Schulich, who provided me the mentorship I needed to see my big idea come to fruition.